Apical periodontitis, AP. These are the radiographs of AP associated with pulpal necrosis, untreated, long-standing pulpal necrosis. These are the radiographs of AP associated with substandard endodontic treatment of different materials, poor techniques. Histopathologically, AP is an assortment of different pathologies: granulomas, cysts, abscesses, actinomycosis infections, and fungus. Clinically, AP is an asymptomatic disease. It's bacterial, progressive, extremely slow in progression. It's destructive as it destroys bone and resorbs roots. It is 100% associated histologically with root resorption. Clinically, the problem manifests only at the late stages in about 25% of the cases. Because it is very slow in progression, it takes years to develop. As we have seen, 13 to 20% within 4 to 7 years after crown preparation and placements, 5% after veneering, and definitely after pulp-capping, direct pulp-capping, caries pulp-capping, and all of that. However, the most significant one of international proportion is substandard endodontic treatment, 20 to 64%, and globally 52%. So as we have indicated, with pulpal necrosis is 1.5 to 5%. With standard endodontic treatment, you may have a good root canal, acceptable root canal, but you still have a persistent infection. That could be from causes other than endodontic treatment or the technique, or could be because of cracks or case selection and other factors. The percentage of incidence or prevalence associated with substandard inferior endodontic treatment is an astronomical 20 to 64%. And it is our purpose to focus on AP to prevent it and treat it. Once the AP is established in the maxilla or the mandible, it can spread. In the maxilla, spreads to the sinuses, the floor of the nose, or adjacent fascia, or interproximal between the teeth to the buccal vestibule, or it actually creates what looks like a periodontal problem, isolated periodontal pocket. In the mandible, it spreads to the buccal vestibules, the submental space, sublingual spaces, etc. Clinically, it manifests as swellings, as we see in these cases over here, or opens up a fistula tract in where it is chronic, or forms an IPP, isolated periodontal pocket. Here, it has spread extraorally into the facial spaces. Here, spreads to the floor for the nose, and you can see it manifesting inside the nose. The infraorbital spaces in these conditions, and here into the sublingual and creating a Ludwig angina. Here, it spread through the skin and opened the fistula, extraoral fistula. Thank you for listening.